So, today we are going to see about an enthusiastic topic, which is electrocardiography, ECG. Okay, which is very interesting, very fascinating. Basically, ECG has a vital role in day-to-day practice, as can be any doctor, any specialist, but this has a major role to play in your day-to-day life because there are many things which we can pick up with the help of electrocardiography. This is your ECG. So first thing is, I can tell you plenty of examples. Okay, a patient came to ED, your emergency department, having sudden onset palpitation. Okay, and was brought to ED, and he was found that the heart rate is around 150. BP is not recordable, and just you're giving one drug you are giving, one drug IV you are giving, and within few seconds it is getting reverted to normal. What could be the diagnosis? Any guesses? The patient is absolutely fine, sitting fine, talking to you, laughing at you, sharing his life. What could be the drug and what could be the ECG? There's nothing but the supraventricular tachycardia. Supraventricular tachycardia is not, it's not very uncommon. Okay, in people age group of 30 and 50 years of age, patients can present with sudden onset palpitation with hypotension, and they will come to you telling that I'm feeling something is pounding. The next here there will be fluttering sensation of neck veins can be there, and as soon as you give the injection adenosine, okay, within few seconds you can see the dramatic response. And on the other end, there can be life-threatening things called myocardial infarction, which can be diagnosed. Okay, sometimes even your ventricular aneurysm can be diagnosed with the help of ECG. Uh, so I've to start this session. Today is completely basics. Okay, I don't want to take you to any higher level today. It's completely basics. Okay, if you have an understanding why a P wave is formed, why a QRS is formed, why a T wave is formed, what are the practical implications, what are the practical things which you are getting out of each and every wave, every segment in an ECG, that makes the difference. Okay, knowing the basics will help you interpret much complex things, which includes your arrhythmias, acute coronary syndromes, and electrolyte imbalances, anything it can be. So, what is normal? So, that is very important to understand, to remember throughout our lives. Okay, let's begin this class with an interesting case scenario. Yeah, so 30 years old gentleman presented with complaints of cough with hemoptysis for the past 6 months. There's no dyspnea, no syncope, no chest pain, palpitation. He never had tuberculosis in the past. He denies any addictions. So, what are the probable differential diagnoses? Young male coming with hemoptysis and cough. Tuberculosis never there in the past. What could be the differential diagnosis? Yes, I'm expecting some answers. See, I would like to keep this as an interactive session. It will be very helpful. You will be communicating throughout the session. Okay, it's a little long session, but throughout the session, if you keep on communicating, it will be very useful, and you will learn a lot. You will remember a lot of things. So, what could be the differential diagnosis? Yeah. What are the differential possibilities available? Yeah, tell me. Please. So, number one coming to my mind is, even though he had no history of tuberculosis in the past, the first differential diagnosis in developing country still be a tuberculosis. Okay, second thing, some pneumonia. Yes, is it possible? Yeah, still lower respiratory tract infection, some pneumonia can be there. Third, chronic cough, hemoptysis, recurrent hemoptysis. The diagnosis could be bronchitis. See, this is a MRCP scenario. Okay, patient will be given to you telling that this guy has cough with hemoptysis, okay, some vague chest discomfort like that, and an ECG will be given. ECG will be given next. Yeah, looking at the ECG, any clues? Can someone tell me the diagnosis? I'm giving a clue. It's a syndrome. Hemoptysis syndrome. Okay, I'll just point to you some things. Sorry, can you repeat, please?
Carcinogen syndrome.
Carcinogen. Excellent, excellent, excellent. So this is a scenario, classical scenario given in MRCP. So if you see the leads very carefully, okay, there is a positive complexes in avia, positive complexes in avia. This is the key, okay. And the other key is all your precordial leads. Carefully observe all your precordial leads. Your precordial leads are nothing but the leads which faces your heart from anteriorly posterior to posterior. Okay, AP. You just have to will ask. We'll see the lead positions in the subsequent slides. Okay. So generally, you will have a transition. There will be some positive, some negative. This is the normal pattern of your precordial leads. Whereas in this, if you see all the negative, predominantly down. You see this is predominantly down. This is down. This is down. This is down. Everything is down. Okay. So this suggests that the heart is not in the left side; it is in the right side. Okay. So yeah. So this is a very good clue. Correct. So diagnosis is nothing but your Carter-Genus syndrome. Carter-Genus syndrome. Can someone narrate the complexes? What are all the essential components of the syndrome? Okay. Number one, situs inversus. Number two, sinusitis. Number three, bronchiectasis. Okay, this is a syndrome complex called Carter-Genus syndrome. All right. So see, just seeing the ECG, looking at the ECG, you have a prior idea of ECG, how the normal ECG will be, how the normal axis is. Okay, so everything we'll see subsequently. Don't worry. I'm not going to complicate things here. I just want to tell you what is most important. What is the clinching point in catching the diagnosis? Okay. So each and everything, I'll explain the basics. Some hi-fi stuff, not much. Some hi-fi stuff, so that you will know what is standard, what is being followed routinely in our day-to-day clinical practice. Okay, so coming to what is an ECG? What is an ECG? It is nothing but a graph. Okay, we are going to record the electrical activity happening inside the heart by using your ECG, your graph. We're just making a drawing out of the electrical activity which is happening inside our hearts. Okay, the conduction system is located endocardially. It's inside the heart. Okay, we are looking from above, from outside, what is happening inside the heart, the electrical activity which happens inside the heart. Okay. All right. So what is finally it is what it is? It is a time and voltage. It's a time voltage plot. If you carefully see an ECG, two axes. This will be your time and this will be your voltage. Okay. This is what we are looking at. Okay. So normal conduction system. This diagram, this is actually a live picture which we have highlighted the conduction system. Okay, if you carefully see, I'll mark and then zoom it. All right, so yeah, you carefully see here. This is the sinoatrial node. The sinoatrial node. Okay, this is nothing but the pacemaker of the heart. Can every muscle cell, every individual cell in the heart create intrinsic rhythm? Yes or no? Is it possible for every muscle, every tissue in the heart to send an intrinsic rhythm? Is it possible? Yes? It's possible. It's possible. Each and every tissue in your heart can produce its own pulses. Whereas everything, functions as a unit, one unit, depending on the SCA node. Correct. So SCA node is a commander. It gives the command what rate you should go at, what speed it should go. Everything, the command is decided by the SCA node. Okay, the maximum, the maximum rate can be produced none other than the SCA node, which is maximum capabilities there with the SCA node. Okay, so that's why it is called the pacemaker of the heart. The normal pacemaker of the heart is the SCA node, which has its ability to produce maximum number of heartbeats. Then from there, multiple bundles will communicate. So multiple bundles will be there. Multiple bundles will communicate. Multiple bundles will communicate. Okay. This SC node, the impulse in the SC node will activate the atrium, and this will transmit to the AV node. Okay, this is the AV node. This is the AV node. Then comes your bundle of this. So, AV node. Then comes the bundle of this. Then your left bundle branch, right bundle branch. Left bundle branch has two, anterior fascicle and a posterior fascicle. So that's how the conduction system spreads from the SC node. Okay, yeah, let's see in detail. So this is a manual drawing of what is there in your conduction system. First, where is the SC node located? The SC node is located in the junction of your SVC and right atrium. We saw in the previous picture. Okay. Whereas the AV node is located in the posterior portion of the anterior septum. And remember that there are three bundles which can connect your SA node to the AV node. Okay. The anterior, middle, and posterior. Okay. Okay. So the three bundles, 1, 2, 3. So anterior, middle, and posterior. See friends, knowing the basis is very important for understanding what is happening in the ECG. Okay, what is being recorded in the ECG. Okay. So just pay close attention. If any doubts, please stop me anytime. Please ask your doubts so that we can go slowly, take it gradually, so that we can understand the subsequent days. It will be very, very good. Your arrhythmia understanding or ACS understanding will be very good. We'll have a lot of, I'll be displaying a lot of ECGs for you so that we can have a discussion on what is going wrong there, what is the probable diagnosis, what are all the possibilities, what are the differential diagnoses. We'll have subsequent discussions in subsequent days. Today I will be projecting all the basic things. Please pay your attention, close attention. Okay, yeah. So these are the three bundles. Okay, so the middle is called your Linky-back bundle. Linky-back. Okay. And your posterior is your thoral, THOREL, thoral tract. Okay. So there is another bundle called Bachmann bundle. This Bachmann bundle connects the right atrium and the left atrium. Okay. It makes the activation of the atrium, both the atrium. Okay. And then this goes to your AV node. From there it reaches the bundle of this. Then comes your left bundle branch, right bundle branch. Okay. So left bundle branch, remember that left bundle branch. This is the left bundle branch. This is the left bundle branch. It has two branches actually. Okay, one anterior fascicle and posterior fascicle. Okay, there are two branches for the left bundle, which is nothing but your anterior fascicle and the posterior fascicle. Whereas the right bundle branch is single. Okay. Only one right bundle branch, and from there it will split into your Purkinje fibers. This is the Purkinje fibers, which will be innervating entire endocardium. Okay, and it will make the ventricle to get activated. This is how a normal activation happens. In the subsequent slide as well, I just going to project the same thing again for reinforcement. Okay, so here lies the SA node, here lies the AV node. The three bundles connecting down. Then from AV node we have your bundle of this. Then comes your right bundle branch, left bundle branch, left anterior fascicle, posterior fascicle. Then your Purkinje fibers, which are innervating into the endocardium and making the ventricles activate. All right. Hope you got it. Got all the points till now. Okay. So now comes an interesting, important concept for your ECG, which is nothing but your activation of ventricles or the depolarization. Okay, so what is depolarization? What is repolarization? So this is very important to understand. So what is depolarization? This is nothing but the activation process of your heart. Okay. When a stimulus hits, for example, when the SA node gives an impulse, that has to activate the atrium and the ventricle. Okay. And the atrium should contract, the ventricle should contract. So the activation process is nothing but your depolarization. Then after activation, the muscle cells, the individual conduction system, everything will come back to neutral state. That coming back process is called as repolarization. So this is depolarization and repolarization. Coming back to resting state is called as repolarization. So what are the different kinds of cells which we have in our heart? One is your muscle cell, one is your conduction system cell. So these both are very, very important, have their own intricacies, both are different in some aspects. Okay. So these two are the action potential curves. Why am I taking to your physiology? This is very important to understand. Okay, we discussed the anatomy earlier. We discussed from where the impulse starts, where it goes. Okay. Now come to the physiology, because this physiology has its implication in the manifestation of various waveforms in the ECG. Okay. I'll be showing in the subsequent ECG, subsequent slides. Okay. So first comes, there are, see, if you carefully see, how many phases is there? There will be 5 phases. One is phase 0, then phase 1, 2, 3, 4. Okay, so phase 0. Yeah. Phase 0 is here, phase 1 is here, phase 2 is here, phase 3 is here, phase 4 is here. So if you carefully see, there will be 5 phases. Okay, so this is the action potential curve of a muscle cell, your cardiac muscle cell. Whereas this is the action potential curve, your conduction system, your generators. Remember that even your AV node and the ventricle, even the junction, everything has its own potential to give a pacemaker. For example, when a patient has MI, myocardial infarction, there can be block at the level of AV node. Then the junction will start to produce its impulses. Okay, it will carry on the heart rate. But the junctional rhythm is not as powerful as SA node. The SA node can fire at very high rate, whereas junction will fire at around 60, 40 to 60 like that. Okay. Ventricular rate will be less than 40 generally. Okay. But there is one rhythm which happens with revascularization. When you are giving thrombolysis or lysing the patient with the injection, either streptokinase or inactive place or tiplase, and the patient's blood vessel is revascularized, blood started flowing into the coronaries back. So you remember, it's 100% occlusion causes a STEMI. Generally, 100% occlusion of the coronary, epicardial coronary artery, or LAD or LCX or RCA will cause a ST elevation MI. Okay, in such cases, okay, once you are revascularizing, either with a stent or percutaneous coronary intervention, or using your thrombolytic agents, then the heart will go into a rhythm called accelerated idioventricular rhythm. It is one of the signs of successful revascularization. Okay, so in such scenarios, the ventricle will go at a higher rate, that is accelerated rhythm. Normally ventricle rate will be around 40 to 60, whereas when it gets accelerated, it will go up to 100. That is called accelerated ventricular rhythm. It's a sign of successful revascularization. Coming back to the basics, so there will be 2 kinds of cells in our body, in our heart. One is your muscle cell, another is your pacemaker cells or conduction cells. Okay, where SA node, AV node, everything. Okay, so this second thing is the action potential. This thing is the action potential of your conduction cells or your SA node or AV. Okay, whereas the first thing is action potential of your muscle cells. Okay, so what are the various phases which occurs? If you carefully see, there is a phase 0. So what is it? It is a rapid depolarization. A rapid depolarization. So what happens? Normally the cell is electronegative. Okay, sodium influx, lot of sodium, potassium ATP pump is a sodium will, lot of sodium will enter into the cell. Sodium influx will cause you rapid depolarization. Okay, so rapid depolarization. All right. Then what happens? Then phase 1 comes. So what is this phase 1? What is phase 1? It is a rapid repolarization. So we start the rapid depolarization. Goes from here to the negative state. The resting event potential is minus 90 millivolt. From here it goes up, rapid depolarization. Then comes the rapid repolarization. All right. Okay. Then a plateau phase. That is your phase 2. Okay. Then comes a slow return, slow repolarization phase. That is here phase 3, and comes your resting state. Okay, that is your phase 4. Okay. All right. So first, what happens? Sodium influx occurs. Then this channels get deactivated. That causes rapid repolarization. Then the calcium influx occurs. So that causes your calcium influx causes your plateau phase. The calcium influx. Then the potassium efflux. Okay. So the potassium efflux occurs. I'll show you. Yeah. So this phase is potassium efflux. Then coming back to your resting state. Okay. If you carefully see in this, the resting state is not flat. See, in this muscle cells, no, once it reaches a state like this, there will be a flat state. That is your phase 4. Again, it goes up, again, it goes up. Like that, it goes up. Whereas in your pacemaker cells, okay, in your pacemaker cells, what happens is the phase 4 will have a spontaneous depolarization. So, see this area, carefully see, it won't rest. You go up, come down, again, go up. It's like that. So this is the property of your impulse producing cells, your pacemaker cells, your SA node, AV node. Okay, fine.
Sorry.
Yeah.
Can you please recap from the phase 1 to 5? It was a bit fast for me and the voice was low.
I want to repeat it. I want me to repeat this thing, right? Phases of your action potential, correct?
Yes.
Yeah. Okay. So, all right. So, am I audible now? Yes. You can hear me, right?
If you can tune up the voice a bit.
Okay. Sure. Fine. So thing is, I'll be a little louder. Okay. The first phase, which is the phase 0. Phase 0 is nothing but your rapid depolarization phase. Okay. Which is by the sodium influx. Okay. And the second will be by a rapid repolarization phase. Okay. The phase 1. Phase 1 is your rapid repolarization. Phase 2 is your plateau phase. Phase 3 is a slow repolarization phase. Okay. And phase 4 is your resting membrane potential, resting phase. Got it? Okay. The rapid depolarization is brought by the sodium influx. Rapid repolarization by cessation of the sodium influx. The sodium will stop. The sodium entry will stop. This inactivation of the sodium channels will lead to rapid repolarization. Then the calcium influx occurs. Okay. That leads to your plateau phase. And then the potassium efflux occurred. Okay. That causes your slow repolarization phase. Then comes the resting state. Is it okay? Got it?
Sorry, the 4. There was said if I get you right, you said the sodium influx is for the rapid depolarization phase. Rapid
Sodium influx
repolarization.
is the sodium influx. Rapid repolarization is the sodium influx will stop suddenly, abruptly.
Yes, so when it stops, it becomes rapid repolarization. That's phase 1.
Yeah.
Then
Yeah.
phase 2, you said phase 2 was the plateau phase. You said something about calcium. I didn't get the calcium.
Calcium influx. Influx. Yeah.
Okay. Then there's
Then comes the potassium efflux.
The phase 3 is the potassium efflux. That's the slow repolarization phase.
Yeah.
Then the phase 4 is the resting states.
Yeah, correct.
Okay, all right.
You're
Thank you. Thank you.
Yeah, all right. So I told that each and every cell is going to produce its own action potential curve. Am I right? So each and everything, SA node is going to have its own action potential curve. Atrial muscle is going to have its own action potential cell. AV node is going to everything, every bundle, everything is going to produce its own action potential curve. Okay. And when you combine together and record in an ECG, you will get the final waveform. Okay. Right. So see, SA node is having its own action potential curve. Atrial muscle is having this, AV node is having this, everything has its own action potential curve. So if everything combined together, that will lead to this ECG waveforms. Got it? The summed electrical activity of all the cardiac muscle fibers is the ECG. Okay, yeah. So coming the same thing, I'm just going to repeat it. Okay, there will be difference in concentration of the ions between the extracellular fluid space and the intracellular fluid. Okay, once there is stimulation, okay, once the SA node sends impulses, okay, then the depolarization occurs. Okay, the outside of the cell becomes negative, inside becomes positive. The current spreads from the depolarized area to the polarized resting area. Okay, this is given by a diagram here. Okay, so what happens in the resting myocardial cell? Resting myocardial cell. So If you see carefully, inside of the cell is negative. Okay. Whereas when the cell gets activated, okay, so when the stimuli strikes it, okay, what happens? There is lot of positive. It is going to change. The membrane is going to convert to positive. It is going to go. See, it is going this way. Okay, so positive, 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 and the negative outside is becoming negative. Okay, that is your depolarization. Outside becomes negative and inside becomes positive. Okay, so first it starts like this, then it becomes like this. Okay, then it will travel throughout the entire thing, and through gap junction, it is going to the next cell. Okay, so and remember, so this is an important thing. So yeah, actually there is an error in the slide. I just want to. Okay, I'll tell this concept in the subsequent thing. Okay.
Excuse me, sir.
Yeah.
Yes,
Yeah.
there is an error. Depolarization will be the arrows you have shown. Repolarization will be represented by the same vectors.
Repolarization.
Repolarization, the direction of arrow will be just like that of depolarization.
Correct. Just like that. Okay, so there is a concept. I just want to bring it here. Give me some time. I'll just call it. Yeah, I'll just. I will proceed further. Then we'll subsequently we can go. I think. All right. Wanted to display the notes. One second, just try to project it back. Yeah, all right. Want to take the picture to some other slide or yeah, the content is very important. Is the screen visible now? Yes. Yes. Is it visible?
We are seeing you only, not the
all
not
right.
the
I am
slides.
sorry.
No
Okay.
problem.
Okay. I'll again project it.
Yeah, it's okay. It's okay now.
Once. I want to share the writing screen actually. Just trying about
Okay.
it. Yeah, I got it. Yeah, hope you are seeing the writing screen now. Yeah, fine. So, so this is the very important point. Okay, for individual myocardial cells. Okay, so depolarization and repolarization proceed in the same direction. Okay, whereas for the entire myocardium, depolarization proceeds from the innermost layer, the endocardium, to the outermost layer, the epicardium, and repolarization proceeds in the opposite direction. Got it? Let's assume I'll draw and show you. You can hear me? Yes? So this is the heart. Okay. This is your epicardium. This is your endocardium. Okay. So for individual muscle cells, okay, both will occur in the same direction. For example, the cell is here. Okay. We told that it is electronegative, then everything will is positive. Then again everything will become negative like this. Whereas for the entire myocardium, depolarization proceeds from the innermost layer to the outermost layer, whereas repolarization proceeds in the opposite direction. Okay. So you have a lead here which is recording. Okay, this so normally for depolarization is occurring here in this direction, and so then it will produce a positive waveform. Okay, and if the repolarization is also occurring in the same direction, it should produce a negative waveform. That is the normal process. Whereas in heart, looking at the individual cell, it happens like that, but looking at the whole heart, it is not like that. Okay, so the repolarization occurs like this, and repolarization occurs like this. Okay, that is how a normal heart action potential for the whole heart happens. Okay, so that is the reason we have a QRS complex which is positive and a T wave also which is positive. Can understand or not? Yes or no? This is very important to remember. Got it? Yes? For individual muscle cell, okay, see, I drew it, I had a drive, we've seen a diagram already. Normally it is negative here, positive here. So as the depolarization wave spreads, everything is becoming positive, 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 positive. This is becoming negative, 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 negative. Okay. Finally, as the repolarization wave spreads, what happens? This will become again negative, 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 negative. So both will go in the same direction. Okay. So when the depolarization occurs, this is happening towards the lead. If there is a lead, for example, a 1v2 lead is here. Okay. This will record a positive response during depolarization. Whereas when it is repolarization also occurring in the same direction, this will record a negative waveform. Okay. Whereas for the entire heart, remember that it is not so. Okay. The depolarization occurs like this. Okay. And the repolarization occurs like this. So that's why your QRSS generally indicates your ventricular activation or a ventricular depolarization, and the T wave indicates the ventricular repolarization. So both are recorded in the positive side. Okay, both are positive, both are up, okay, above the baseline. Okay, got it? I hope you got it. You all got it. Fine. So this is how your all the waveforms are coming. Okay. So as such, the P wave, your sinus node activation will not have any effect on your ECG. It's just going to show a flat line. Okay, only when the atrium gets activated, there will be a P wave. So generally, the sinus node will not produce anything, whereas the entire atrium is activated, that will produce your P wave. Okay, then as the entire ventricle activates, that will produce your QRS. Okay. Then the ventricle relaxes or repolarizes, that will produce your T wave. Okay, this is how your normal activation process. Fine. There are various waveforms in the ECG, right? Okay. If you look at the waveforms, generally in V1, if you see, small upslope, then there will be downsloping like this. Then comes to the basement. Then the T wave will come. This is how V1 will be. And if you carefully watch the V6, how will it be? There will be small downslope. Then it will be this positive from QRS. Then it will be like this. How come this is occurring? Why is this occurring? What is the reason behind each and every waveform? We are going to see in this subsequent slides. Okay. Yeah. So how does it happen? It happens in 3 phases. So finally, see what is vector? Vector is nothing but the summed electrical force. Okay. We have seen in the previous ECG, if you remember this previously. See, if you see this slide, multiple electrical forces are happening, multiple things are happening, multiple action potential happening inside the heart. But finally, everything is recorded as a single waveform. Okay. If you see finally, where is the net electrical force coming from? Okay, it is coming from this side. It's coming from this side to this side. It's coming from the side, yes or no? Because let's say notice how located here. Whereas finally the ventricle is activated, and in the ventricle activation also the left ventricle has the maximum muscle mass, so that is going to produce a big impact in the ECG. Okay, so finally the net electrical activation will be from above your from above to downwards towards the left side. Okay, above right to below left side. Okay, that is how your net force of all your action potential is. Okay, and your LV mass has a big impact on that also. Okay, so generally this happens, the activation of ventricles happens in 3 phases. Okay, number 1 is your activation of your ventricular septum, or the depolarization of your ventricular septum. Okay, then comes the depolarization of your free walls of the ventricles. Okay, and the final part to get activated is your posterobasal wall of your left ventricle and the posterobasal septum. So each and everything will produce its own waveform, and that leads your ECG manifestation, especially leads V1 and V6. Okay, let's see in subsequent slides how they are being produced. Okay, yeah. So if you look at this is a vector 1. What did we discuss about vector 1? The mid septum gets activated, okay, and it is from left to right side. Okay, so what happens? This vector, the initial vector is from left to right, especially during the activation of your septum. So it is going like this. All your vectors. So what happens is in V1. So V1 we'll see the location in subsequent slides. V1 is located right side, right parasternal area, important process space. Okay. So when the septum is repolarizing, it's going from VC, it's going from left to right. It is going like this. Okay. There is a V1 here. So this V1 will record a positive amplitude. Okay. Whereas V6 is located behind. Okay. V6 is located in the axillary line. Okay, so that will produce a negative. So this is the initial waveform. If you carefully look at V1 and V6, the normal waveform will be V1 will be slightly positive and V6 will be slightly negative. Okay, this is happening after the P waves. Okay, I told P waves is because of the atrial depolarization, okay, or the atrial activation. After that, there is a flat segment. Okay. Then comes this waveform. This is because of the ventricular activation. Starting thing is generally a positive complex in V1, whereas in V6 it will be a negative complex. That is because of the septal activation. Okay, got it? Yeah. So then comes your second vector. It is going to activate all the ventricles, lateral walls of the ventricles. Then comes the posterobasal area of your ventricle. So the lateral part of the ventricle, which when it activates. Okay, so what happens is V1, I'm told V1 is looking at the right side of the heart. Okay, right side of the heart. Initial activation from left to right of the septum. So the V1 had a positive vector or positive amplitude in the ECG, whereas then starts the ventricular activation, the ventricular wall activation. Which wall has the maximum muscle mass? It is your left ventricle which has the maximum muscle mass. So that leads to positive complex in V6. Okay. So initially there was a negative complex. Remember the initial waveform in I'll draw and show you. So the initial waveform was positive in V1. Am I right? Correct. V1. Whereas in V6, how was it? Initial waveform was negative. It is because of the septal depolarization. So then comes your free wall. The entire muscle mass of the ventricle is getting depolarized. So that will produce a positive, big positive wave. So big positive wave. I'll just draw and show you again. Yeah, big positive wave in V6, whereas a big negative wave. It's a big positive. See, V6 is positive. The entire vector is going towards V6. So that will produce a negative waveform in your V1. Got it? Hope you all got it. So the initial waveform. Okay, then the second waveform. Then finally what happens? Then the posterobasal area is getting activated. Okay. So the posterobasal area is getting activated. That what happens to V1 then? It is coming back to the, it's going to a gentle initial positive, then a big negative, then it is coming back to the baseline. Okay. And V6, what happens? V6, small q initially, a small wave, negative deflection, then a positive deflection, then it's coming back to the baseline. Okay. So this is how the 3 phases of action potential or 3 phases of ventricular activation, your ventricular depolarization happens. Hope you all got it. Yes, any doubts so far? Please stop me anytime. Okay, I'm very happy to explain you, and we can discuss, take this discussion further. We can even, I can, even if I'm not able to answer your questions, I can answer in the subsequent classes also. Am I audible to you all? And hope that I am clear to you as well. Yes, shall I proceed further? Fine. So let's look at this. So if you carefully see, I'll zoom and show you. All right. So we are discussing about the leads V1 and V6, correct? So if you carefully see the V1, the small or the positive complex, then comes a negative complex, then again it is going back to baseline. As if you see the V6, okay, small Q waves, which is not mentioned clearly here, then comes a positive complex, then comes to the baseline. Okay. And the transition happens. Generally, if you see initial V1, V2, if you carefully see the V1, V2 leads, okay, there's a small positive complex, then a big negative complex, then going to the baseline. That positive complex is gradually increasing. If you see V3, more of positive and less of negative, correct? So generally, this transition occurs, okay, in V3, V4. Okay. Normally, this transition occurs. So from a more negative waveform to more positive waveform occurs over the V1 to V6 leads. I will explain you everything, all the lead positions in the subsequent slides. So don't worry. Let's proceed further. Okay. Yeah. So this is how. This I just have to. I kept you to see, tell you like how a normal ECG looks like. Okay, and what all the leads we have, how to record, how the paper speed will be. Everything we'll be discussing in the subsequent slides. So don't worry about that. Okay. So if you carefully see, V1 is there, V2 is there, V3 is there. Okay. Then there is a VR, a VL, a VF. Then we have leads V1, V2, V3, V4, V5, V6. Remember that this everything is an individual camera which is looking at heart from various angulations. What are the various angulations? We'll see in the subsequent slides. Okay. So we have kept multiple cameras to look at the action potential, how the heart is getting activated. Okay. That's what the ECG is. Nothing special about it. Okay. Yeah. So how to record? How to record this ECG? Yes. So how many leads are there? How all they came to existence? That we'll see. Okay. So in the last slide, if you remember, it's in multiple leads, correct? So how many are there? You calculate 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 12 cameras are there. In reality, we don't have that much leads to be kept in the body. Okay. In reality, if you see, there will be 6 leads for the chest. Okay. And we connect your left arm, left leg, and your left arm, left leg, and your right arm. Okay. Everything connected with this thing, with a lead. Okay. And this will be manipulated to produce a ECG waveform, which is nothing but your 12 lead ECG. Okay. How we are taking the 12 lead ECG? Let's see. So in general, we have 2 kinds of leads called bipolar leads and unipolar leads. Okay. Bipolar leads records the potential difference between 2 leads. For example, your left arm and right arm. What is the difference between left arm and right arm? Okay. And left leg and right arm. Okay. And left leg and left arm. So these are the different. So we will record the difference between these 2. Okay, your right arm and left arm. Okay, so like that we record the difference between these 2. Okay, what is the vector going in between? How is it going? Okay, like that we'll record. That is your nothing but your bipolar leads. Whereas unipolar leads record just at the lead. Okay, for example, if V1 is kept in the right side, okay, close to the sternum, right fourth intercostal space, we keep another neutral area. Okay, we call it as indifferent electrode. Okay, by connecting the other leads, we'll keep a negative. We just have to have a negative to make a positive reflection in the ECG paper. Okay, so that we keep. Okay, that is nothing but an indifferent electrode, which is a collection of multiple leads. We connect multiple leads and make it as a negative pole for this lead to record a positive waveform. Okay, so those are called as unipolar leads. Okay, and there are some leads called as augmented leads. Augmented leads also is you're just making the mission to make a lead. Okay, it's not a real lead, it's just an augmented lead. You are making a mission to create a waveform by connecting leads together. That we'll see in the subsequent slides. Okay, it will be more clear to you. So we discussed about the bipolar leads. We have three bipolar leads. Okay, so three polar leads and bipolar leads are nothing but your 1, 2 and 3. So what is the positive input? Your positive electrode for that one, your left arm is your positive electrode and right arm will be your negative electrode. Okay, so show you. This is just for your understanding. This will not have any implication in your interpretation of the ECG, but you should know how these leads came into existence. There is an axis system called hexaxial system. So how this axis system came into existence, that's why I'm just putting this slide. Okay, just get an understanding. That's more than enough. Okay, we are not going to real life, we are not going to see right arm, left arm, and you just have to know the labels. Okay, this lead, this will connect like this, and we'll start taking ECG. That is more than enough. Okay, and finally the computer is going to give you ECG, you are going to interpret. So that makes the difference. Okay, interpretation makes the difference, but understand what is behind this axis system. Okay, so yeah, so for lead 1, left arm is positive, right arm. So for lead 1 is, where is left lead 1? See, lead 1 is here between the left arm and right arm. Okay, and lead 2, what happens? Your left leg and right arm. Okay, this is lead 2. And lead 3, your left leg and the left arm. Okay, so we have already 3 vectors, 3 lines. Correct? We have 3 lines. 1, 2, 3 lines are. Yes. All right. So this is how you connect. So lead 1 is for the right arm and the left arm. Correct? Yeah. Lead 2 is between the left leg is your positive and right arm. Correct? Yeah. Left arm and your left foot is your lead 3. Done. We got 3 leads. Then augmented leads. So augmented leads, what we do is, okay, so the positive electrode will be right arm augmented lead, right arm will be a positive too. These two together will be your negative electrode. So this the machine will manipulate and make a trace out of it. Okay, AVL left arm, AVL is here left arm, whereas these together, right arm and left leg will be your negative electrode, and left leg is your AVF. AVF is foot, correct? Foot electrode. Left arm plus right arm is your negative electrode. So this gave rise to 3 more lines. Yes or no? Previously we saw 3 lines like this. 1, 2, 3. Okay. 1, 2, 3. We saw 3 lines in the previous line. Correct? Yes. And if you're seeing here, we got 3 more lines. Correct? So one is going like this. One is going like this. One is going like this. 3 lines. We got 3 lines. Okay. Yeah. So how this came into existence, I have just given a picture. Okay. And finally, so precardial leads, where are they kept? Precardial leads, V1 is kept in the right sternal margin at the 4th intercostal space. Okay. So the negative thing for this will be negative electrode will be, it is the mission calculated Wilson central terminal. It will connect the all other 3. See, your right arm, left arm, foot will be connected together. Okay, that will come as a negative electrode for this negative. Basically, to record waveforms, you have to have a negative and positive, right? So the positive will be your just leads V1, V2, V3 like that. The negative will be by connecting all these 3 leads together. Okay, that is something called Wilson central terminal. Okay, fine. So the right sternal margin, 4th intercostal space will be your V1. Left sternal margin, 4th intercostal space will be your V2. Midway between V2 and V4. So this is usually asked as a multiple choice question in many exams. Okay. So what is the location of V3? Like that they will ask, and they will give multiple options to confuse you. Without placing V4, it cannot keep a V3. Remember that. Okay. So how you should place normal ECG leads? V1 can be kept. V2 can be kept. We have a bony landmark. Okay. Next lead to be kept is V4. Then comes V3. Okay. So then comes V4. V4 is nothing but mid clavicular line, intercostal space. Okay. And then, so 1, 2, then 3, then comes this V3. V3 should be kept between V2 and V4. Then in the anterior axillary line, at same horizontal plane as V4. Then mid axillary line, same horizontal plane as of V4. Okay, got it? So all these things are there. All these things are in fifth intercostal space. Okay. Then we have extra positions which we keep for right ventricular leads or your posterior leads. Okay. So RV leads. So what is RV leads? RV leads, we keep this V1, V2, we keep as constant. Instead of keeping in the left side, we'll keep this in the right side. Okay, just for recording the RV activity better. Okay, V4R is very, very, very important lead. V4R, V4R. Remember V4 on the right side is a very, very important lead. It should give you multiple clues whether the lesion. If you before taking a acute coronary syndrome patient for a PCA, you get an understanding where exactly is the lesion, whether it's the proximal RC or distal RC or the circumflex. We'll get an idea with the help of V4R. It's very, very, very important lead. Okay. So, and we have special positions for recording the posterior wall ST elevation myocardial infarction also. So, in routine clinical practice, okay, this is a advice for you to practice well in your life, come out well in life, and not to miss any acute coronary syndrome patients. If you have a patient with typical chest pain, and if you have an ECG which is showing nothing, typical chest pain, sweating, profuse sweating, having severe chest discomfort, which is lasting more than 10 minutes, it's not a typical angina, it's not a stable angina. Okay, patient has come to you and you're seeing like severe chest pain and you're giving nitrates. He's taking sublingually, you're keeping no improvement at all. Doctor, I'm not having any improvement. I'm not able to bear the pain. He's telling, he's shouting at you. He's saying, I'm not able to bear this, doctor. Then you are seeing the ECG. There is nothing. You're repeating ECG, nothing. So what will you do? Remember, not to miss out a posterior wall infection or an infarct related to circulatory. This 12 lead ECG, there is fallacy that it can miss the circulatory infarct. We have three main coronary arteries: your left anterior descending, right coronary artery, and left circumflex artery. This 12 lead ECG can miss out the circulatory infarct. Okay, so it is always important that whenever a patient is having typical chest pain, always don't forget to take a right ventricular and a posterior wall leads. Okay, those will give you extra information. You might be able to pick a patient of acute coronary syndrome STEMI by taking those extra leads. Okay, always in a scenario, in a clinical scenario, if you have a patient with severe chest pain, don't take one ECG and keep quiet. Please make sure that you repeat ECG at subsequent intervals. Okay, maybe 20 minutes or 15 minutes. Okay, we had a patient. Okay, one 35-year-old guy has come. He had risk factor. Yes, I agree. So basically, he had a history of smoking. Okay, he has come to our chest pain unit. Okay, and he had severe chest pain, and he told, "Sir, I had severe chest pain, but as after I come in here, I'm feeling better." Okay, I was thinking, okay, this young guy, smoking history is there. BACS, let's keep and observe. Okay, I thought, okay, we kept and we did a ECG. ECG was normal. We did a troponin I. We have a rapid troponin kit. It was also normal. Within 10 minutes after arrival, this guy has severe chest pain. Okay, and I told to repeat the ECG immediately. ECG was showing ST elevation. Okay, so be careful about this kind of patients. Okay, always make sure that you get maximum information possible from the ECG before sending them home. Otherwise, there is a disaster. Okay, yeah. So the other leads are called as posterior leads are V7 to V9. Okay, so V7 is lead is kept as posterior axillary line at the same horizontal plane as for V4. Okay, posterior axillary line. Then V8, where do you keep it? Okay, posterior scapular line. And V9, where do you keep it? Left border of spine as the same level. Got it? Yes. Hope that you got understanding about these leads. There are three bipolar leads: 1, 2, and 3. That is because arm, left arm and right arm, leg and arms. Okay, we had three vectors going like a triangle. Okay, then we got three more vectors by having augmented leads. Augmented leads is your machine created leads. Okay, you have a right AVR is there for right, left there is a lead AVL, and foot there is a lead AVF. Then we have 6 chest leads with Wilson central terminal as the negative. Okay, and the various questions we have discussed before. All right, you got an idea? Fine. Shall we proceed further? Yeah. So this is how. So we have just plotted the same, see multiple lines we have seen. 3 lines for unipolar leads, 3 for the augmented leads, and then 6 for your chest leads, correct? So if you overlap everything, okay, so a triangle like this. You have a triangle like this, correct? So I just make them crisscross. You got it. Okay. Then we have your AVL, just extrapolate this here. Okay, AVR is here, extrapolate it here, and your AVO is there. Okay, so if you extrapolate them here, you will get your x-axial diagram. Okay, so this AVL comes to minus 30 degree. Okay, this one is 0 degree. Lead 2 is 60 degree, plus 60 degree. Lead AV is 90 degree. Lead 3 is plus 120 degree. Okay, and AVR will be minus 150 degree. Like this is 30, AVL is 30, and this AVR will be minus 150 degree. Okay, so if you extrapolate those lines, you get your x-axial diagram is formed. Okay, based on which you will interpret the axis. Remember that normal axis is minus 30 degree to 100 degree. Okay, so from here, this area, so this area is your normal axis. So this area is your normal axis. When you have a patient having ECG with axis from minus 30 to plus 100 degree, you mention or label them as having normal axis. Got it? Okay. Yeah. So this is the same thing, same diagram. We have kept extrapolated and put multiple degrees. Okay, this is for axis interpretation. So AVL is minus 30 and 0. Extrapolation of AVR is plus 30. Then lead 2 is plus 60. Then AVL is plus 90. And lead 3 is plus 120. Got it? These are the various axes. So coming to the ECG per se. So what is ECG? How is it being recorded? What is the time and amplitude? Which we discussed already. It's nothing but the time amplitude chart of your heart. Time amplitude chart of your heart. So in the ECG paper, okay. So if you zoom in, see there are multiple. If you carefully see, if you carefully see, there are a lot of large boxes, lot of small boxes, lots of small squares. Yes, correct. So what does each box mean to us? We'll zoom in. Okay, so we have zoomed this large box, and we can find that there are 5 lines horizontally and 5 lines vertically. Yes or no? 1, 2, 3, 4. So let me show you. So we have just extrapolated this box into a separate area. So if you see, each line will correspond to 1 mm. Okay, each line will correspond to 1 mm. Okay, and so 1 mm is equal to how much millivolt? 0.1 millivolts. If we discuss that, this will be in millivolts, this will be in seconds, not milliseconds. Okay, so if you carefully see, there will be each large box will have 5. So see this 1, 2, 3, 5. So one large box will correspond to each small box is 1 millimeter corresponds to 0.1 millivolts. Okay, so the height will be 0.5 millivolts. 0.5 millivolts. Okay, so the large box, if we calculate, the height will be 0.5 millivolts. Okay, whereas timing, each and every small box correspond to 0.04 seconds, and totally if you calculate, it is 0.20 seconds. Got it? Understood? Vertically it is 0.1 millivolts. Horizontally, if you say, it is 0.04 second, okay, or 40 milliseconds. Okay, this 0.20 second we will label as 200 milliseconds. Okay, so this is your normal ECG paper. Okay, and the paper speed, usually the speed of the paper which runs in an ECG is 25 millimeter per second. 25 millimeter per second. So what is the importance? So if you want to see each and every wave beautifully, nicely, you have a ECG patient with tachycardia, you're not sure what is the ECG is conveying, whether there is P wave or not, whether it is hiding somewhere. I'm not able to make out clearly. Then what you have to do is you have to run the speed. There is a setting in the ECG machine to change it to 50 millimeters per second. Okay, so that if you have an ECG like with the fluorescence, everything like this will be shown beautifully in the 50 millimeter second ECG. You get the advantage. Okay, there is an option in the ECG machine to change the settings, and you can nicely see all the waveforms. So if you have a patient with tachycardia, you are not able to clearly delineate whether it is there or not, whether it is running constantly or irregular, then please try to change the setting to 50 millimeter per second speed and try to take the ECG. You can see beautiful waveforms. Got it? Fine. So how each and everything occurs, how on each waveforms occurs, why is it occurring, and what does it denotes? So that's what we are going to see here. Okay. So basically there is a small error here. I'll point to it and I'll inform you as well. So first we have P wave, correct? So if I have time, I can read little more in depth. Then you can read Balthasar. Okay, if you want the real standard has been kept in many countries. Shamroth is there. Shamroth is a very good book. Okay, but much of the things I didn't base from that because I felt Goldberger and Balthasar very easy, very effective, and the way they put in and they make you understand and help you in retaining things. It's very good in those books, Goldberger and Balthasar. So of course, many of the content is from there only. You can go through, be very helpful. Go through it, not only go through it, keep on applying in your day-to-day practice. That is very important. Yes, doctors, any other doubts?
Sir, can you write the name of the books in the chat box?
Sure. I can write in the slide as well. I'll just write it, I'll show you so that you can, yeah. Balthasar, second is Goldberger. Okay. And third, this book is considered as Shamroth. Okay, but this book is good, but to retain and recall, I am not sure. I am not happy with that book. I have read it multiple times, but I find it difficult to recall. Okay, and the Bible books for cardiology is Braunwald. Okay, Braunwald. We call it as well. So, but that is specifically for cardiologists. For ECG, these three books are very good, more than enough. Another book is Marriott. So I base my slides on those books only. This will give a very good understanding about ECG. Final thing, most important thing is practice. You should keep on seeing. You should kind of keep on collecting ECGs. Okay, whenever you find an interesting ECG, please save it. Okay, I use multiple apps for saving and collecting ECGs. Like I can tell you, like one is your Drive, Google Drive. I have subscribed it and I got this thing. So I usually save it Google Drive or Evernote. Multiple things where you can store and you can keep notes along with that, and or you have this thing. So Evernote is a paid version. OneNote is also there. So many things are there. You can utilize. You can see whenever you are seeing interesting ECG, please take a photo, save it, keep some notes below it so that you can recall, revise anytime, and will remember it forever. So that's very good. Keep on collecting ECGs right from now. So you'll have a good collection of ECGs, and you will remember and you can read it, you can enjoy that. Basically, you can write a case scenario also. Like this patient came with so and so complaints. ECG was showing this. Finally, we got to know that the diagnosis is like this. So it'll be very interesting to learn, and you'll be learning, and you will become very confident for a period of time. So that's how we learn ECG. ECG is like a music notation only. Like the more you keep on seeing, the more you remember. That's all. Yes, doctors, any doubts? Anything else from my side I should contribute now? Anything I have to give you now? In subsequent classes, we'll be learning about rate calculation, abnormal rhythms, and then we'll know about the axis, basic axis, how we calculate what is right axis deviation, left axis deviation. Then chamber enlargements, each and every channel enlargement, how will it manifest in the ECG? Then we'll go with acute coronary syndromes, how these acute coronary syndromes manifest. ECG, what are the changes? What are the chronicity? Like chronologically, when it starts, how it will manifest, and over a period of time, how will it change? Then we'll discuss about arrhythmias, both bradyarrhythmias and tachyarrhythmias. And I'll try to enforce, I'll put some points from your NHS guidelines, also resuscitation guidelines. Okay, and then finally we can have a quiz. Patient, I will put ECGs, you can tell me what are the findings. So this is how the classes, the sessions are going to be very interesting. So all of you are enjoying the session, I hope that. So thank you for your patient listening. So we close for this day. Anything else from your side, doctors? Yes?
Thank you so much. Thanks a lot.
Thank you. Thanks a lot. Thanks a lot.